Thank you for having me. So, been with the Florida Center 21 years this past January, so I know a little bit about what we do, and it's a fantastic place to work, and I can't sing its praises enough. I think the culture of our organization is fantastic. We love working with young children and helping families, and especially families that have experienced a lot of struggles in their life. So, the Florida Center, tonight you're going to hear about the only FASD clinic in the state of Florida, and it's right here in Sarasota at the Florida Center. It is the only state-run clinic, so we're very proud of that. We get referrals all over the state of Florida. We have folks coming in from as far north as you can imagine in Florida and as far south as Key West, so we are taking referrals all the time. We get a lot of local referrals because, of course, you guys know about us and you're referring your kiddos, but we do get a lot of statewide referrals because the word is out. Our funding comes through the Department of Health for that program, so the word is out all over the state, and we can't keep up with the referrals. It's really crazy. Our budget for that program used to be about $650,000, and now it's down to about $280,000. So we really need more funding for that program, so talk to your representatives. We also provide early childhood therapy services in the form of speech and language, occupational therapy. We also provide infant and early childhood mental health services for young children. We can provide that in the community to anyone in the community, regardless of socioeconomic status, but we also provide a lot of services for children that have experienced some sort of adverse experience. We do a lot of work with children in the foster care system. We get a lot of referrals from case managers in our circuit. We have been really involved in judicially in court-related services for infants. Back in 2000, we received one of the 3 infant mental health pilot projects in the state that started in Miami with Judge Lederman, and there was a lot of great outcomes for that. We've been very involved in the national model, the Safe Baby Court Team's national model, and we helped to get the early childhood court program off and running here back in October, which we've really been meeting with folks in our circuit for a number of years. Judge Hayworth was really instrumental in helping to get that going, so we're really excited about coming around to the end of our first year in early childhood court. So if you're not sure what early childhood court is, I'll be happy to talk to you afterward. We also provide prevention services, Healthy Family Services, which is a home visiting program to prevent children from entering the child welfare system. So these are high-risk families who have young children birth through 5, and we go in homes and help families understand how to bond and take really good care of their children and really avoid some of those risk factors that might lead to removal of children. So we look at ACE scores. If you're not familiar with that, maybe most of you probably are. If not, I hear there's going to be some training in the future regarding adverse experiences and trauma. But we really go in and help families in 5 different counties avoid having their children removed through the Healthy Families program. Let me see, what else? Preschool, we also have preschools in our sites. We have a site in Northport and Sarasota, and we provide inclusion model classrooms for children birth through 5. And inclusion, for those of you who don't know, means we have children that are typical, meaning normal, if you will, and children that have developmental delays in the same classroom. So research shows that children who have developmental delays will learn from their typically developing peers and move along a lot faster than if they were in a classroom with all developmentally challenged children. So we are really proud of that model, and if you haven't been out to our center and you're interested to learn more, please let me know and we'd be happy to schedule a tour. So we're going to talk a little bit about fetal alcohol spectrum disorders. We got funding through a budget request back when Governor Bush was in office, and he was really instrumental in helping us to get the funds, so we're very appreciative of that, and we've been able to keep most of them. The Ounce of Prevention used to fund us, and they no longer do, unfortunately, but we still have our Department of Health dollars, and they used to give us about $380,000, but unfortunately our current governor vetoed about $100,000 of those dollars few years back, and so now we're down to about 280, and we're operating on a shoestring budget, but we're getting it done. And we do a lot of good work in that clinic. So fetal alcohol spectrum disorders is a disorder that it's a kind of an umbrella term for a range of disorders that occurs when a mother consumes alcohol during pregnancy. That is the only way you can have fetal alcohol spectrum disorders. You can't get it any other way. You can't get it because your dad drank. You can only have a fetal alcohol spectrum disorder if your mother consumed alcohol at any point during her pregnancy. We're going to talk about what that might look like. Because there's a lot of questions about, well, what if she only drank once, or what if she drank, only during this month but not the rest of her pregnancy, or what if she drank at the end of her pregnancy and not the beginning, and isn't it okay to drink in the third trimester, and all of these questions that people have. But that is the only way you can have a fetal alcohol spectrum disorder. Fetal alcohol syndrome is the most common of the disorders, and that is, the syndrome means you have to have a certain number of characteristics in order to have a medical syndrome, and we'll talk about what those characteristics are. But most of you are familiar, if you're not even aware that you're familiar, are familiar with children that have just prenatal exposure to alcohol in general. And those kids typically look normal. They might even be of normal height. They don't have any strange facial abnormalities, but these children, there's clearly something going on with how they behave, how they follow rules, how they learn. So it's important for us to wonder a lot, everybody say wonder a lot, and not make assumptions about what's going on with children when they're able to repeat rules but not follow them. Because I think common sense would say, well, if you know what the rules are and you continue to not follow them, then clearly this is willful disobedience, right? Not so. And we're going to learn why here in just a few minutes. So, fetal alcohol spectrum disorder is a cluster of physical and mental defects present from birth. So this is present from the moment a baby is born. That is a direct result of a woman drinking alcohol while she is pregnant. Drinking alcohol is the most dangerous thing substance a mother can use during pregnancy. It's more dangerous than anything else that you're hearing about. It's not to say that those things are good and preferred. It's just saying that the long-term implications are absolutely known. It has been known for the past 40 some odd years that consuming alcohol causes permanent, irreversible brain damage. It is a teratogen that literally kills or damages cells on their way to become a heart, a lung, a brain, an arm, a leg. Those cells, if you think about how a baby is created, there are a number of cells that come together that have to divide in order to become a human. And as those cells are migrating, they multiply and they migrate to go to where they're supposed to go. And the alcohol consumption gets in the way of that migration. Fetal alcohol syndrome, as I mentioned, is the most severe outcome of a mother using alcohol during her pregnancy. This means that the child has these specific features and as a result has the most severe outcome, and those are facial features, prenatal or postnatal growth deficiency, meaning the baby didn't grow while in the mother, and after the child is born, perhaps the baby is not growing. Prenatal exposure to alcohol is either confirmed or unconfirmed. You can still diagnose fetal alcohol syndrome or spectrum disorder with unconfirmed alcohol exposure if you have a lot of other data that says it's pointing in that direction, right? So we don't need to know that mom drank, but if we know mom has a history of using alcohol, and we know that the child has facial features, and we know that the child has growth deficiencies of some sort. And we'll talk about how we measure all that, because it's not just somebody's subjective view of whether those things are present. There's an algorithm for how we determine those things. So when we look at the facial features, just so I'm feeling rushed, and I want you guys to know that this is a rushed presentation. I'm going in July, for instance, to do a 6-hour presentation on this topic, because this is a very involved, detailed topic that is hard to rush through, but I am for the sake of time. And if you have more questions, I'm happy to do part B or talk to you on the phone or whatever. So I want you to know that I'm rushing through, but I know you guys have a time frame. So the eyes, these are the things that we measure in our clinic. We take photographs of every individual coming into our clinic, and we have facial analysis software that we load the picture into, and we measure 3 characteristics that have been known to be present for all individuals who have the face. Not everybody has the face, but for those that do have the face, they have the narrow eyes. So we measure the eyes, the distance from the outside corner. These are called palpebral fissures, and we measure the outside corner to the inside corner across the nasal bridge, from the inside corner to the outside corner, and we get a measure. We look at the upper lip. Right up here, this groove you have, it's called a philtrum. So you're all going to go in the bathroom and check yourselves out. We all have a philtrum. Some of our philtrum are just the way they are because that's how God made us. And sometimes we have a flat philtrum because our mother used alcohol during pregnancy. Now, there are other things that can cause flat philtrums. There's all kinds of drugs that can be taken, pharmaceuticals, for instance. Depakote is one, for instance, so you can read in your spare time online about those things. But alcohol absolutely causes a flat philtrum, and it has to do with the way the face is formed during pregnancy. So in the first trimester, if the mother is using high levels of alcohol, that's when the face is going to be present. If a mother is incarcerated for the first 3 months, she got pregnant, she's incarcerated, doesn't drink alcohol for the first 3 months, that baby's not going to have the face, okay? The mother can get out and use alcohol for the rest of the 6 months during pregnancy, and that baby's definitely going to have the brain, but it's not going to have the face, so they're not going to have the syndrome. But they're definitely going to have the brain of a kid with this syndrome. The final thing that we measure on the face is the upper lip circularity. So if you look at this child, you see that the eyes are very narrow. There's a wide spread here between the 2 eyes. They're very, very narrow here. And there's something in the corner called an epicanthal fold. And that is not something we measure, but it's something that can be and is often present when we look at the eyes. The philtrum is flat. There is no groove. And the upper lips, there really isn't a circularity. That, like when you think about a heart, there is no heart shape on the top lip. It's pretty much like a Cupid's bow. So those are the things that we measure. And if you look here, this is a perfectly developed philtrum and a nicely shaped upper lip. This is not. So you see the difference when we go here and here, okay? So that's a big difference. These are basically a lot of the physical abnormalities that can be present but aren't always present. The facial features that we talked about are there in a large percentage of the cases. When we look here, this is research that was done that looked at known exposure to alcohol and what kinds of physical abnormalities were present and the percentage of those physical abnormalities. And this is a longitudinal study that took place over 20 years. So I'm happy to send you any of this that you want. Just get me your email, and I'm happy to do that. I'm taking the sign-in sheet wherever it is, so you can put your email out beside your name. And I need the sign-in sheet, too, by the way. For our state dollars, they require that we tell them how many people we trained. So fetal alcohol spectrum disorders. So similar to autism spectrum disorders, there's a spectrum. There's a range of effects that can happen. Because if a mom drinks during the first trimester or the second trimester or the third trimester, or if she binge drinks one weekend and then doesn't drink for 2 more weeks and then she binge drinks another weekend, or if a mom drinks 1 glass of wine every day of her pregnancy, these are all different variations of alcohol consumption. And what effects do all of these things have? Well, that's why it's a spectrum, right? Because they can have all sorts of different impact on the developing brain of a baby. So this is an umbrella term, and underneath that umbrella are the range of effects. And there's about 22 different diagnoses on the spectrum, ranging from what's called static encephalopathy, which is basically a fancy way of saying brain damage that isn't going to get any better. It's kind of going to stay there. It's not going to get any better. It's probably not going to get worse, but it's just there. And don't expect the child's IQ or ability to adapt throughout his or her day to get any better. Come on. So as the baby develops, cells that will become the brain, nervous system, and nervous system attach to each other. Alcohol interferes with this development. The baby's brain may be smaller structurally or functionally damaged, with the right and left hemispheres unable to communicate with one another. So when we look at the child in our clinic, we're looking at the face, we're looking at the growth. That's another characteristic of the syndrome. We look at percentile rankings of the growth. So we look at not just how tall or how much they weigh in our clinic on that day. We need a history. Has anyone been through our clinic? Okay, so several of you. So some of you in here know what we require. We can't just have you call up and say, yep, we'll put you on the schedule, because this is present from birth. So if your child is, say, 10, we've got 10 years of data that we need to know about. Because if we're just evaluating that 10-year-old, we're missing a lot of information. So we have an intake coordinator that helps us to gather as much as we can about that child's earlier years, right? So we want to get OT reports, we want to get school records, we want to get pediatric records, we want to get all sorts of things. We want to know about mom. If she was arrested during her pregnancy for some alcohol-related offense, that tells us that mom used alcohol during her pregnancy, because sometimes it's hard to know and hard to get that documented. And by the way, confirmed alcohol exposure doesn't have to be written. It can be anecdotal. Grandma Susie can say that she saw mom, and that can be a reliable source to us, because we trust that Grandma Susie's not got an ulterior motive here. She's just trying to help her grandson. So this is a visual of a baby born with an FASD brain and a baby born with the typical brain. And you can see that not just the size is different, but the actual structure of the brain is different. So when we talk about what we look at, the face, the growth, this is the other part that we look at. We look at the brain. We look at not just how the brain is structured, but we look at how it's functioning. So those are scored throughout our clinic process, and we look at the functioning through the variety of professionals that are present during the FASD evaluation. We have a psychologist, a speech and language pathologist, an occupational therapist, and a mental health professional, all part of the interdisciplinary team that takes place during the clinic evaluation. And they're all looking at different things, because this is a whole child disorder. This isn't just a brain-based disorder. It is a brain-based disorder, but there are other contributing factors that we want to look at. So the way the brain functions, we look at various, the OT looks at how the child is able to deal with space and their body's awareness in their space. Are they able to grasp a pencil? The speech and language pathologist looks at what their articulation is. Are they able to express their language? Are they able to receive language? How do they interpret language as it's coming in? The psychologist looks at adaptive functioning. How much help does your child need to get through his or her day? Right? How much help do you all need to get through your day? Most of us can get through our day pretty okay, right? I guess. But some of our kids, we wonder, are they going to be able to get through their day as they get older? Because they're forgetful. They're not good with time. They're not good with money. They forget things. So they're not able to learn. Their IQ is low. So how are these kids going to be able to function as adults and get through their day? And that's what's called adaptive functioning. These are visuals of brain scans done. The top left is a normal brain, if you will. And then as we move along, these are brains that have been impacted by alcohol to varying degrees. There is, I don't have a pointer, but at the brain stem, if you can see the brain stem, as it goes all the way up, there's this thing that looks like an ear that's kind of on its side. If we look at the top left, this little white piece that looks like an ear, kind of, but it's kind of like this, that's your corpus callosum. And that is what separates our right brain from our left brain. And as you look across the other brain scans, that piece is almost absent in some of them. So when we expect our right and left brain to talk to one another to help us get through the day, if your brain looks like mush, it's really hard to make that happen. It's really hard to be mindful of what you're doing, to understand consequences. See, in schools, they want to take away things. They want to take kids from recess. They want to say, oh my gosh, you're not able to participate in this party. You can't go on this field trip. We want to take things away. We want to have consequences for behavior. And when you have a child with a brain like that, you're wasting your time. Consequences are not going to work because they are not immediate. You almost have to erase the idea of consequences and give immediate instruction during that moment and say, and it's so basic. You're not going to teach a kid like that long term that through consequences. You're going to have to be immediate, teaching them hands are for touching nice. We don't hurt, we don't slap kids, or feet are for walking, not kicking. I mean, you have to really be in the moment with those kids because they're not going to learn, and you have to do that repetitively. These kids never remember to wash their hands after they go to the bathroom. You could tell them something a million times, and they just forget, and they just have a brain that doesn't retain a lot of information. And a lot of these kids look perfectly normal. We had a call from an investigator a couple days ago, and kudos to the investigator. He wanted to know, there was a child at a local school that was saying something about that somebody had done to him, and the investigator wanted to know if we could evaluate this child to see what his cognitive level was because he wasn't sure if the child was telling the truth. Well, you know what? I think that's so amazing because these kids, they confabulate a lot, which is lying. Like, oh my gosh, you lied. But not really. They make stories up, and people don't think that kids make stories up. If you hear a kid saying that somebody did something to them, you want to believe it. But these kids can make things up. They can make up horrible things, and it can be horribly devastating for the caregivers that are taking care of them. Anybody ever had a kid make up a story about you? Yeah, so it happens, and we have to wonder about that. Obviously, we want to believe kids. We don't want to think kids are lying, but we also want to be wise. If we think that a child might have some cognitive deficiencies, we want to wonder about that. So sensory integration is something that we look at, our occupational therapist looks at, and it begins at conception and continues through childhood, and it matures at about 8 to 10 years. Sensory integration is really how we interpret our environment through our various senses. You're all sitting here in a chair, your hair might be touching your neck, you've got a shirt on. We're all kind of interpreting our environment through our senses. You're hearing me, you're looking at me, you're smelling things. There's all kinds of things going on. For children that have brains like we saw in the last slide, sometimes there are certain things that might impact their brain differently, and we have to wonder about that, especially young children. And so occupational therapists are really good at helping children get that movement and get those sensations kind of worked out. It's a nervous system issue, so it's really important to seek an OT to really help us with that. Oh, let's see here. All right, we did that one already. Sensory integration is a developmental process, and it takes place in our central nervous system, and I've just explained to you what it is. This is kind of our normal brain. We have like the cop kind of in the middle, organizing everything. How I feel, how I smell, everything I taste, how my body moves, my body in space. I notice none of you are falling out of your chair. You have good body and space awareness, right? Most of you walk through the doorway. You didn't bump into the walls as you're walking through, so this is good things. Most of you probably stay in your bed all night. You don't fall out because you know you only have so much room to move. These are body and space awareness things. This is a typical brain and how our brain kind of interprets all of these things. When you have a brain that looks like mush, you interpret your environment like this. And I think we've all met somebody and we go, man, what must it be like to be in that brain? It must be so hard. But for us as adults dealing with those children, we have to be real mindful of our experience of that child and temper ourselves to respond in a way that that child needs. And if you don't know how to do that, then there are people like me who can help you. It's really hard. It's really hard work. And I'm not telling you anything. I'm preaching to the choir. All right, come on. So some intervention strategies that can be used, obviously we want to assess the strengths of the child. We want to look at sensory, motor, language, cognitive, emotional, social. We want to wonder about what's going on with these kids. We want to seek help, call somebody like that investigator did. I'm so impressed with that guy. I called him and told him so. I love to see when folks who you would typically not think would think like that, and that tells me that he's clearly got some great training. Treatment plan should build on strengths, improve deficits, and enhance functioning. We want to really make sure that we're not treating behavior. If we're treating behavior, you may as well just be putting a Band-Aid on a cancer patient because you're really not treating the cancer, right? We can't do that. So we have to make sure that professionals know what they're doing, that they're asking the right questions, and they're actually treating a brain-based disorder. There are a variety of interventions for adolescents and young adults. We do see a few adults throughout our year. Most of the folks that come through our clinic are children, but we do have a few adults that come through. We want to create structured environments. That's key. Establish clear and set routines. And for some of us, that's easier to do than for others. Provide supervision and coaching skills. It gets exhausting to repeat things over and over, but you have to. Use simple directions when giving instructions. See, sometimes we are so busy, we say, go do this and do that, and then go do that, right? Because we're busy getting through our day, and we just got home, and the house is a mess, and you got to cook dinner, and maybe I'm just talking about my own life, but, so we have to stop for a minute and give simple instructions and recognize what this child is capable of doing and set realistic expectations. Pictures are fantastic, so if any of you have thought about doing this and haven't yet, do it. Put pictures on their drawers, for instance. If the shirts go in the top drawer, put a picture of a shirt on the drawer so they know. Don't put words, put shirts, put pictures. Pictures are great. Do storyboards. Do like a morning routine board, like a piece of paper, and put it in a little plastic slip cover and say, first we do this, and then we do that, and then we do that, and use pictures instead of words. That works beautifully for all young children, but definitely for children with brain-based disorders. Teach coping skills for stress management. And again, somebody like me can help with that. Give brain breaks frequently. I needed a brain break yesterday. I emailed somebody or texted somebody who needed to meet with me, and I said, I need a brain break. Give me a half an hour and then come by and see me, because my brain was just fried from what had been going on that day. So we all need brain breaks, but we need to recognize when our kids need brain breaks, especially during homework. It's like, oh my gosh, we got to get homework done, but sometimes they can only do it in bits and pieces at a time. So give them a brain break. Let them go do something and then come back to it. Be flexible in what you're allowing them to do. So we have to check ourselves as adults raising these kids and be flexible in what our expectations are. So mental health therapy isn't always going to be ideal for children with brain-based disorders. You have to really understand if the child's cognitive level is capable of understanding mental health treatment. We provide an intervention called Families Moving Forward, which is really the only intervention we found for children with these kinds of brain differences. And it really is a caregiver focus. What are all you? Caregivers. It's a caregiver-focused intervention. It's not a drop your kid off and please fix him and I'll pick him up when he's fixed. It is a caregiver-focused intervention, which means we help you, kind of like Caesar. Anybody watch Caesar? He rehabilitates pets and trains the owner. Yeah, we rehabilitate children and we train the parents on what they need to do because your children get better because of you. The multidisciplinary team approach is key, and that's what you get when you come. You have just checking my time here. Oh, I'm doing really good on time. Am I? Yes. You have a speech and language pathologist. You have all those folks within that team meeting, and they meet with you, and depending on the age of the child, the younger the child, the longer the evaluation will be. So for, say, a child under 2, we don't need a psychologist, because I believe the psychologist is involved for children that are like 2.6 and over. So we're done in like 2 hours, but for older kids, we can be there for anywhere from 5 to 6 hours, and then for teens, we're sometimes there for a full day, because remember, each of those professionals have to have that child for a period of time throughout that day. The individual, we all come back as a team, we convene, I share my piece, the OT shares her piece, everybody shares their piece and their results, and then we generate a diagnosis based on all of those categories that I mentioned earlier, the face, the brain, the alcohol exposure in utero, and the growth. And then we bring the family in and we share with them what our results are. And we let them know what our recommendations are. We handwrite all of those recommendations that are shared. Each of the professionals write everything down. The parent gets a photocopy of those handwritten recommendations, and then within about 6 to 8 weeks, they get a full-on. Anybody seen one of our reports? They're pretty long and extensive. They're anywhere from 15 to 25 pages, depending on what we evaluate. So these are, again, some of the clinical interventions that we might recommend: the brain gym, relaxation techniques, yoga, anything that helps the child to become mindful. Self-talk sometimes, problem solving is huge, helping any child to problem solve. Families moving forward, again, our caregiver-focused intervention, it is 2 hours a week, every other week. So we meet with you in your home, or you can come to our office. And we have a very prescriptive routine and intervention schedule that we implement. And then we let you kind of implement it, and then we come back 2 weeks later and we talk about what's happening and how has it been going and have you been doing X, Y, and Z. We actually just did a week-long training for Michigan. Michigan has a very robust fetal alcohol program. They have a robust everything in Michigan. They're pretty robust in their infant mental health arena too. And they just hired us to train their state folks. We trained about 20 people in Michigan on Families Moving Forward. We're going back in October and we're going back in April. So they're investing a lot in this area and for people to treat individuals with this brain-based disorder. Most children that have confirmed issues related to prenatal exposure to alcohol will require some sort of medication, basically. Their brain is just so damaged, there's no way that they can function on their own. So I don't know what your beliefs might be about medication, but the reality is if your brain looks like one of those brains that we saw, your brain needs help. And it's not going to be through behavior interventions that your brain is going to get better. Your brain needs help, and most of these kids need a psychiatrist who is informed about brain-based disorders and who is willing to try and learn about fetal alcohol and what alcohol does to the brain. And often it's a combination of medications and not just one particular, because these kids, they have memory issues, they have attention, hyperactivity issues, they have learning issues, so. And these are just some. We don't recommend using one drug to offset the effects of another drug. If you find yourself doing that, then we need to figure out why the first drug is not working as well as it should, especially for kids with brain-based disorders, because then what you end up doing is just adding more meds to combat the side effects of the other. And then, of course, close medical follow-up. We almost often recommend further evaluation just to rule out other syndromes, because there are so many syndromes out there. We don't want to assume that it's fetal alcohol. If there definitely could be something else, we almost always recommend someone have genetic testing. We will also recommend neurology, just to make sure if we don't have any kind of brain scan or anything from a neurologist, that we recommend that, just to make sure that we're not missing something in our evaluation. So some of the universal protective factors, there we go. A child living in a stable and nurturing environment for over 72% of their life, imagine that. And we're talking about children with brain-based disorders as a result of prenatal alcohol exposure. For these kids, they need to have as much stability as possible. So if you think about, it's unfortunate we couldn't get a video to work. I have a video about kids in care and the impact that alcohol has on these children in care, lots of data. Most kids coming into care are exposed to drugs. I think we forget about alcohol because people just don't talk about it. It's just out there. Most people in this room probably have consumed alcohol or do consume alcohol. Alcohol is always a factor. People don't just use one drug typically. People are polysubstance users. So it's hard to tease out with drugs what caused what. We know what alcohol does to the brain. So we can definitely assess for that. But when you add on neglect, separation from primary caregivers, exposure to domestic violence, exposure to abuse, you just kind of compile the insults to the brain, right? And so our job is to kind of tease out those environmental factors from those organic factors that occurred during pregnancy. Being diagnosed before the age of 6 is big. It really boils down to early intervention, which is what we do. Never having experienced violence, which is often not the case. If your brain is affected by alcohol, then there's usually some other unfortunate adverse experiences that come along with that. And then staying in each living situation for an average of 2.8 years, which means what? If you're in a living environment for at least, say, 3 years, 2.5 years, what does that mean? You've had the opportunity to what? Bond, connect, attach. That goes a long way. I mean, hopefully we would not have to remove children after they've connected to someone for that long. I never like to see those situations happen, and unfortunately they happen all too often. But as a wise judge told me once, that the law will always trump best interest, which is a hard pill to swallow. Experience a good quality home. Experience a good quality home from the age of 8 to 12 is another protective factor. Having applied for and been found eligible for developmental disability services, having a diagnosis of FAS rather than FAE, which is an old term, but basically that's the new spectrum. So having fetal alcohol syndrome is actually a benefit. It's a protective factor because it's actually identified as a disability. Having a brain that has issues, but no other issues that go along with that is a real challenge. And we have tried to advocate for those kiddos who have some real challenges, but a lot of them have pretty normal IQs, and they're kind of just barely getting by, but the family struggles so much with them on a day-to-day basis, it's really hard to get services. And then having basic needs met for at least 13% of their life. And that doesn't seem like a lot, but that's what the research tells us. So this is a visual, and I think this visual is one that I use a lot. So it gives you a really good idea of how the brain of somebody with fetal alcohol exposure might function. So if the actual age is 18, their expressive language is that of a 20-year-old. So that means that this 18-year-old can carry on good conversation, they have great vocabulary, and if you're talking to them, you're going to really think they've got it going on, and that they are wise and smart and can really get through life. But what you don't know is they read 2 years behind their chronological age. Their social skills are that of a 7-year-old. Their comprehension and emotional maturity is that of a 6-year-old. Their money and time concepts, these folks are running out of gas, literally. They are not making it to work because they can never get there on time. They can't keep schedules because they're not good with time and keeping schedules. They are functioning at an 8-year-old level in that respect. Anybody got an 8-year-old? You know what that's like. You got to remind them about things. When was the last time you showered? Kind of thing, you know. Living skills, that of an 11-year-old. Now, I have 10 and a half, almost 11-year-olds, and I mean, I'm comfortable with them staying home for a few hours by themselves, but I can't imagine them being on their own. But at 18, you can absolutely live on your own. And when your living skills are that of an 11-year-old, imagine that. We've seen some really sad cases of adults that have come in and have been really taken advantage of by their adult peers because they are functioning like this, and they're very gullible, and they're the ones that are going to be taken advantage of. They're the ones that you're going to find in the courts. We've done 3 evaluations for death row inmates at our state prisons, and it is absolutely horrific when you listen to these stories and you hear about their ACE scores, you hear about what they were charged with and why they did it. It's really sad. I promise you there are a lot of folks sitting on death row that might have a brain like that. In summary, fetal alcohol syndrome is a devastating developmental disorder that affects children born to women who drink alcohol during pregnancy. Although FAS is entirely preventable, children continue to be born to mothers who have drank alcohol. Results of drinking during pregnancy affect the baby, our family, and society. It costs us millions of dollars a year to treat a child who has been prenatally exposed to alcohol. If you think about the expense of their birth, any maybe NICU expense, then you move on to developmental therapies they might need, then you move into the education system, the amount of work that it costs to put in additional services in their classroom, perhaps the additional services they need in terms of speech and language. Think about the people that have to work on their IEP, their 504 plan. When you talk about the extra therapies, maybe aquatic therapy, maybe horse therapies, maybe, who knows, the judicial system, perhaps, because one of the secondary factors or risk factors for these individuals is mental health and involvement in criminal justice. So that is a huge cost to our society when we think of it in terms like that. So it is a huge cost, so we're all paying for it. The cost of FAS and FAE or spectrum disorders are tremendous to us both personally and professionally. I had a foster family say, hey, we're adopting children that have known prenatal exposure to alcohol, and the subsidy that they're going to give us is not going to cut it. It's not going to be able to help us afford the things that this child is likely going to need. Can you help us write something that tells the folks that are determining the subsidy, help them understand what it is that we're going to need? So it's something that you really have to think about, because unfortunately these children are expensive, and sometimes they never leave you, and you don't know that when you get into it. Tips for you guys is really don't sweat the small stuff. If you have a short fuse or you're easily frustrated, you got to check that, and you got to do some real soul searching on that part of you. Choose 1 or 2 critical behaviors at a time to work on, because these kids are exhausting. Typical kids are exhausting. These kids, they'll wear you out. Be firm, yet flexible. Rigidity can increase oppositional behavior. If you are a strict parent and your kind of go-to as a parent is to be strict and a rule enforcer, you got to really think about that if you think you have a kid that's got some brain-based issues. And honestly, fetal alcohol aside, children that come from neglectful situations have brain-based issues already because of the trauma they've been exposed to. This just adds to it. Remember, they are not willfully trying to make your life crazy. Allow yourself to grieve the loss of the whole person or the child you thought they could be. Don't expect them to act the same way as every other child, and that's hard because people in the community and at Publix and at Disney and at wherever you go with your child, they have no clue what's going on with your kid, and they are looking at you like you have 5 heads, and that's just kind of what you sign up for. They are not like children who don't have brain damage. They are very different. Keep the mood positive, and that's with any kid, but definitely with these kids, because when you lose it, what happens? They lose it, right? You escalate, and they escalate. Give 5 times more praise to everyone. Correction. Don't hurry them. Do not hurry them. You want to create anxiety? Hurry them. Defiant behaviors increase when we're under pressure, and that goes for any one of us. Do you get more defiant when people are like, come on, hurry, we're going to be late, right? You're like, shut up, leave me alone. So we feel it when people do that to us, so be mindful of that, right? The circle of security training, which is one of the interventions we use, it says that you really kind of have to be on as a parent 30% of the time, which I think is a really great percentage, because I think I can do that. So give yourself some slack too. You don't have to be perfect. We're all going to fail. We're all going to flop. You just want to do your best. Don't take them places where they're likely to have problems, right? So you have to really think about where you can go. Do something fun with them every day, and it doesn't have to be big. It can be fun while you're driving in the car, fun while you're taking a bath, or fun while you're doing whatever you do, but just make it fun, right? And that takes energy on our part, because we're tired and we have grown-up things to think about. It will make you feel better about them and yourself, and it will also build your relationship with them. Do something for yourself every day. A good, warm bubble bath. And this is coming from my boss, our CEO, Catherine Shea, who adopted a son from Harlem Hospital with fetal alcohol syndrome about 28 years ago. So she knows better than any of us, and he will never leave her. He has fetal alcohol syndrome, and he will never leave her. He's still there. These are the sites nationwide where we have FASD clinics. It's unfortunate that they're not everywhere, but you see Florida's there. And then these are just some of the goals of our program. We want to increase statewide diagnosis and intervention. We want to provide statewide training. And as part of our contract for the state, we do training all over the state for free. We do not charge for any of our trainings. Once we meet our deliverable numbers, we might charge folks. We would never charge you guys, but we might. But usually we're providing free training all over the state. And we do go all over the state. Like I said, I'm going to Tallahassee in a couple weeks. We want to provide intensive intervention. We want to seek additional local, state, and federal dollars. And we want to explore how we might leverage federal dollars through Medicaid and other funding sources. And really, fetal alcohol syndrome, fetal alcohol effects, clinical suspect but appear normal but never reach their full potential. These are the children, these are the characteristics of the kids that have prenatal exposure, and this iceberg is a great illustration. What you see on top is if you look underneath, there's so much more, right? So it's the tip of the iceberg that we say, and it really, that's what it is. It's an invisible disorder. People can't see it. So often we think it's just behavioral and willful behavior. That concludes my presentation, and I think we have a little time for questions. Surely somebody has a question. You have 3 questions? Okay, so your question was how many characteristics on the list of all the percentages of physical abnormalities do you have to have in order to have the fetal alcohol syndrome? So in order to have fetal alcohol syndrome, you have to have the face, you have to have the brain, you have to have the growth, and you have to have prenatal exposure to alcohol. That is it. The face, the brain, and the growth. And you have to have the face, meaning you have to have the eyes, the philtrum, and the upper lip. That's the face. You have to have the growth, which means that you have to be within, you have to have multiple measures over time that are under 3%, the third percentile, which is 2 standard deviations below the mean. So pretty significant in terms of growth deficiencies, and you have to have significant either brain damage, structural damage, or brain function challenges. And those also you have to have 3 areas that are 2 standard deviations below the mean. So basically 3 areas where you're significantly challenged. And then you could be diagnosed with the syndrome. So she asked if we would consider mom getting busted stealing alcohol during pregnancy as a confirmation of alcohol use during pregnancy. Technically, that wouldn't be alcohol use, but I'll tell you what we would do in a situation. We consult with people all the time, and if someone's calling us saying, you know what, we know that mom used alcohol throughout her life because of this, that, and the other. She was pregnant, caught stealing alcohol, and a number of other factors. We will often take those into consideration when scheduling. The reason we can't schedule a lot of individuals that don't have confirmed alcohol is because we just don't have the space. We don't have the time and we don't have the funds. So we have to narrow it down to those who have confirmation of alcohol exposure. Okay. So genetic testing, it is a microarray of a variety of different syndromes. It'll look for a number of syndromes. Williams syndrome, Fragile X. It looks at just a number of different things. Ours is specifically looking at fetal alcohol spectrum disorders or fetal alcohol syndrome. Okay, we're going to go here and then here. Yeah. So, right. So to have the syndrome, you have to have all of those criteria. If you have some of the face but not all of the face, or you have some brain issues but not all of them, or some growth issues, then you are on the spectrum of disorders, right? So you can have neurodevelopmental disorder, you could have static encephalopathy, you can have a variety of different, and then we help you understand what that diagnosis means for your child. Yes. In the front here. Did you have a question? No? Okay. Anybody else? These are good questions. Yes, here. So there's really no, there aren't studies that that it could be allowed to be done, right? We can't say we're going to have this controlled group who uses alcohol during pregnancy and we're going to see what happens. So what we like to say is that the research that was done back in the 40s, right, or excuse me, back in the 60s, 40 some odd years ago, they interviewed moms they were all these babies that were just born with all these conditions, and they were interviewing moms. And some of the moms, honestly, just binge drank. They just had some binge drinking, a couple maybe for 2-3 months in their first trimester before they knew they were pregnant. Binge drinking is the worst because you're doing high volumes of alcohol in one setting. So it's not to say that a mom, there's a great visual I have on another PowerPoint that shows you like a mom who drinks 1 glass of alcohol during her pregnancy equals this many baby bottles of alcohol that baby would have consumed. A mom who drinks this many during her pregnancy, it equals this much. So it's really like if I had a loaded gun and I passed it around your table and there's only 1 bullet in there, somebody's going to get it. And are you going to take the chance that it's you, right? So consuming alcohol is just not worth it. And we also know that We rarely have birth moms come through our clinic, but when we do, it is a very sensitive time for our clinic, and we talk before we bring the parent back about how to be sensitive with the mom, because we have to be of the mindset always that every mom, every dad wants to be the best they can be. And no one says, I'm going to use this alcohol and damage my child's brain. And there's a lot of shame, there's a lot of guilt involved. So we talk with that parent about what's going on, but we also do it very carefully because they're feeling a lot of shame. There's a beautiful video, there's some YouTube clips of this, Recovering Hope. It's through the Department of Health and Human Services at the federal level, and there are several moms on there who talk about how hard it was to come to terms with what they had done. They're alcoholics, and they had a disease, and this is what happened. And one mom beautifully said, you know, her older son, she said, can you forgive me for what I did? And he's like, what are you talking about? You're my mom. And she's like, if he can forgive me, how can I not forgive myself? It's a beautiful video. I never watch it without crying, but it's a real thing. There's also a national organization called FASD, and they have a private support group that you are only allowed to join if you are a mother who used alcohol during your pregnancy and has a child with fetal alcohol spectrum disorders, because it's moms who know what it feels like to be that mom, and they support each other with no judgment. Yes. It can. Sometimes we do recommend coming back, especially if the child is a toddler. We might want to see them in a few years before they go to school, because we might be able to help them, help the school and help that parent know kind of what to expect as they move into school, what some of the challenges might be to kind of get ahead of that child maybe having challenges, right? To be able to set some things up before they even enter school. Yeah. Yes. In general? I'm not sure. I don't know the answer to that question. That's a good question. That's interesting. Good question. That's a great question. I'm not sure. I'm not sure. Well, thank you guys very much for having me. My cards are on the back. There's information about our center on the back table as well. And if you did not sign the sign-in sheet for me, please do that so I can accurately reflect the number of people that I trained tonight. Thank you so much.